Hi, Dr. Beers. I'm guessing you're there somewhere. I'm glad to see that you are already set. Look at you. You were set.
How's it going so far?
It's going well. I mean, I'm happy that people have come early to make sure. We had a little snafu. We were trying. There were two people per same place, and they wanted to be socially distant, so we had them log on twice, and that doesn't work well for sound.
That
And
creates a lot of echo.
Well, it wasn't just actually, it wasn't the echo as much as just the bandwidth. It just wasn't doing. We got the echo fine, but anyway. Well, welcome. We have someone who's joined. It looks like we have a few people who've joined, probably about, I think there are a couple of us. So Carol is here. But thank you again so much, Dr. Beers. Thank you for all of responding to all of my many emails. And we are recording this session. Obviously it's live as well. It'll be available, and I can let you know where that will be posted when I find out where that's posted. I'm not in charge of where that is, so I'm still learning.
We're learning.
Anything else that you know from me?
From you, I don't think so.
Okay. Yeah, you're very self-sufficient. I was a little nervous about the Mac, but then when I spent some time with it, it wasn't that bad. I mean, it does take a few steps, though.
Different than some of the other modalities, right? I think I was telling Lee I'd not been on this specifically before. It's a little bit different in sort of how you load up your presentation, but
So there's a little bit of a delay. I'm not sure why. It wasn't originally. So you're on two screens?
On one screen.
Oh, you're on one screen. Okay. So then that should be okay. Yeah, I don't think there should be an issue. And people can click. Can you see me as part of this, or no when you're presenting?
So right now, when I flip over to my slides and sort of start moving them, I'll sort of move you over to the side so that I can still.
Yeah, that's fine. No, that's fine. And so, because it has varied by computer and ability. So I was just curious. You don't necessarily need to see me, but I will present. Do you have a preference? Rose seems like a wonderful administrative person. I've gotten to know her.
It takes care of me. Me saying.
Yes, she seems great. I was going to probably. She sent me something that was
a long bio.
Well, I mean, it's not as long as some, but I was thinking of probably not necessarily going into your undergraduate education. Is that okay?
That's totally fine.
And all of that. I probably will just write up, your role on the Council on School Health. I think it's like the first 2-3 paragraph. I mean, it's pretty short. The other one is just as long, if that's okay. All right, great. Well, we have a little bit of time. It doesn't start till 3:30, so you're welcome to turn off your camera and your sound and just chill. I'm guessing.
Clear out a couple.
I'm guessing. Yeah, please do. Thank you again so much, and I'll see you in a little bit.
Be back in a little bit.
afternoon. Everyone, we'll be starting at 3:30. Thank you for coming to this session about safe return to school. We have a treat for you. We have someone, Dr. Nathaniel Beers, who is from DC, and he is representing the Council on School Health with the American Academy of Pediatrics. Welcome, everyone. This is Jerry Matson, and this is a session sponsored by the Women's and Children's Health section. We'll be starting in a couple of minutes. Dr. Beers is joining us from his home in DC, and he will be sharing with us about safe return to school. So thank you for joining, and we'll start in a couple of minutes. Okay, welcome again. This is Jerry Matson. I am the chair of the Women's and Children's Health section in the North Carolina Public Health Association, and this is a session sponsored about safe return to school. Welcome everyone for joining. We have a treat. We have Daniel Beers, who is with us. He is the president at the HSC Healthcare System. He serves as the Chief Operating Officer and Chief of Specialized Instruction and Executive Director for Early Stages in the Office of Special Education in DC Public Schools since 2009. Dr. Beers volunteers as a general and developmental behavioral pediatrician at Children's National Medical Center, where he was the medical director of the Children's Health Center at CNMC. Prior to joining DC Public, he was the deputy director of the policy and programs for the administration of the DC Department of Health and the Title V. He has served on the Mayor's Advisory Committee on Child Welfare and the Children with Special Healthcare Needs Advisory Board. Nathaniel was past president of the DC chapter of the American Academy of Pediatrics. He was also the chair of the AAP National Committee on Membership. He serves on the Council of School Health for the American Academy of Pediatrics and serves in a variety of other roles in the AAP, both regionally and nationally. So welcome, Dr. Beers, and we are looking forward to your talk and guidance and recommendations, as well as some question and answers afterwards. Thank you so much.
In our virtual world, it's my pleasure being. I look forward to the conversation and about the work that is going on. I have some of the work that you've been doing, but always happening at the local level and understand.
You're cutting out a little bit in and out, so just to let you know, sorry.
A little better?
Yeah, that's better. Well, we'll see. I'll let you talk some more.
And I can put headphones off if they're acting.
Yeah, they might be acting a little funny because I'm hearing it going in and out. I don't.
Often.
Oop, I guess we lost Dr. Beers right now, so we will wait for him to return. Thank you for your patience.
I'm back. Can you hear me
Okay,
now?
that's better.
Okay.
Mhm.
Let me share my screen again. Sorry for the technical difficulties.
I think that comes with the territory. And for those of you who probably are used to it, you can click on the slides to see them larger, and you can click on them twice to get them larger, or to click on larger to see Dr. Beers in larger video.
There you go. Okay, so thank you. We'll go ahead and dive in a little bit, and then as Jerry said, we'll make sure that we have time for questions. So there's plenty of time for us all to learn together. I have no disclosures and will not be talking about any investigative products. Today, our goal is to really understand the key components of the AAP guidance on school entry, as well as the current state of school reentry in the United States as it exists right now, as well as understanding how the plan in North Carolina fits into successful reopening of schools. This June, the AAP came out with its first reentry guidance for schools, and that was developed because there were a lot of jurisdictions thinking about how to reopen schools, and that those policies were all focused only on reduction of spread of COVID and not taking into account the huge impact of school closure has on the broader health and wellness of students across the country. And so with that, we put out our first guidance in June, updated that guidance again in August, and have gone through a couple reviews to determine what the right timing is for our next round of updates. But we'll continue to provide updates as new information becomes available. But we wanted to make sure that we put out a statement that we strongly advocate that all policy considerations for the coming school year should start with the goal of having students physically present in school. It doesn't mean that that's possible in every jurisdiction. There are lots of variables in play that we will talk about, but it is a starting place that we should start from, understanding that that is an incredibly important part of a child's overall wellness. I don't have to tell you, but there certainly has been a huge racial and socioeconomic inequality of the COVID virus, as well as more broadly systemic racism associated with schools that we have been having a more active dialogue about during this summer and over the course of the last several months than we have had in recent history. Certainly, we know the COVID impact on Black, Latinx, and Indigenous communities has been greater than on white communities, with increased prevalence as well as increased severity of disease. And those patterns are consistent in both the adult population, but have also now been proven to be similar in pediatric populations as well. We also know that the access to virtual learning has not been equitable, and that there is increased challenges with access to both devices as well as internet access, as well as the appropriate spaces to learn for Black and Latinx and Indigenous communities. As each of you know, many, many children across this country rely on schools for adequate nutrition, with over 30 million children and adolescents relying on free and reduced lunch, as well as breakfast and supper programs. We know that these schools have tried diligently to try and increase access in the community during this period of time, but we also are seeing more and more data that is showing that families are struggling to provide adequate food resources to their children and their families. And finally, we know that because of the funding models that schools are funded under, that the quality of school facilities is not equitable across the community. And we know that those models disproportionately impact Black and Brown communities, as well as poor communities, leading to insufficient investment in school facilities, which at this point creates challenges in reopening as we think about what needs to be in place from a safety perspective and a ventilation perspective. So where are we now as we look at sort of what's going on across this country? As the end of August, about 60% of all school districts across the country were moving forward with virtual learning. About 37% of those counties and school districts were using in-person at least part of the time, with half being in-person time and half being hybrid. And you can see across the map that that continues to change. This continues to get updated, and later in my talk there is a specific link if you're looking to look more specifically across the country what is happening and watching that trend shift. This Burbio School Opening Tracker has been a great resource. In addition, according to the tracking system that Brown University has put in place, we know that over 1,200 school districts are reporting cases of COVID in their schools. And so we'll continue to monitor that. Again, that's self-reported data, and so not necessarily capturing it all. And not all public health departments are reporting out school district specific outbreaks. And so there is some challenge associated with being able to effectively track this. I will note that North Carolina does report out on their website the data, and that is going to be a great resource for each of you as well as for your families and thinking about what's going on in the North Carolina school districts. So what's going on in North Carolina? And certainly, again, this is from the Brown University COVID dashboard. 88% of school districts are in person, according to the data reported by schools. About 7% are in a hybrid status and about 5% in virtual. With over 80% of those doing in person are providing family choice of either in person or virtual. What we do know over the course of the month of September is that student infections did fall based on the reporting data at Brown, as well as staff infections did remain flat. Again, there's some additional data on the North Carolina Department of Health website, but that Brown University does a little bit more depth in that space. That's a helpful tool to be aware of. So what are the guiding principles that we put forward from the AAP about what needs to be in place in order to reopen? Certainly, we know to be able to safely reopen schools, communities need to be taking all necessary measures to limit spread. That means encouraging or requiring face coverings as well as appropriate physical distancing in public spaces, particularly indoor, but also outdoor spaces. We are seeing across this country more and more spread around casual contact that people are having as they go to backyard barbecues and other things of that nature. We also know that those school policies have to be flexible and nimble because we learn more and more about this virus every single day. And what we thought we knew in June was already old news by the time we got to rewriting the statement only 30 days later when we restarted at the end of July. We also know that there's not a single thing that a schools can do that is going to be the magic bullet. It has to be a multi-pronged and multi-layered approach that's focusing on protecting students, teachers, and staff. These policies and strategies also need to be revised and adapt based on the level of viral transmission in schools and community. And I would note that the North Carolina plan for schools does encourage all school districts to think about various levels of engagement based on the level of disease in the community. It's super important, and again, for you as public health officials, won't be a surprise, but we are encouraging everyone to be coordinating together with state and local public health authorities, as well as school nurses and pediatricians and other local health experts who can be a valuable part of encouraging appropriate behavior both in the school and out of the school, as well as ensuring safety for everyone in the community. We also need to make sure that these policies are practical and feasible and appropriate for a student's developmental age. We need to know that what we're going to recommend for that preschool or kindergarten student or classroom may well be very different than we recommend for a middle or high school student or classroom. And we need to make those adjustments to those plans to make sure that we're responding to the population that is in the building. There certainly need to be special considerations and accommodations to account for the diversity of youth in buildings, and certainly as you think about vulnerable populations and think about those in poverty as well as those with disabilities, we need to make sure that we're making adjustments to those plans to make sure that they too are able to return to school safely. Certainly, as we think about children with disabilities, we need to make sure that pediatricians and families and schools are partnering together to collaboratively identify and develop accommodations when needed. That child who has a G-tube feed may well need to adjust schedules. That child on a ventilator who needs suctioning may need scheduled suctioning, even though we typically try and avoid that. But all of those are about sort of making those accommodations. That child who can't access virtual learning at home may need some different type of support to make that happen. And so thinking those through are critical for every child's success. And as we noted at the beginning, all school policies should be guided by supporting the overall health and well-being of children, adolescents, their families, and the broader community. It's not just about what happens inside the school around education, because we know there's so much more. Certainly, these policies have to be consistently communicated to families and staff, and other languages need to be available as needed. And finally, we recognize from the AAP that this doesn't happen without additional resources. School budgets were already strained before the pandemic, and certainly the pandemic is only making this harder. And we know if they're going to be able to implement all the safety measures and support the educational needs for students and staff, even in virtual environments, there are going to be additional resources that are required to make that possible. So as I noted, North Carolina has 3 levels of school plans that are recommended to be in place. The Plan A, where there's minimal social distancing based on the current disease burden, and we'll talk a little bit about that as we move forward relative to the AAP guidance and think through those components. But certainly those are comprehensive measures to control the spread if the community spread is stable or improving. If the levels are increasing in the community, certainly there are additional plan recommendations recommended to moderate social distancing. And certainly if there was widespread COVID in the community and it was substantially worsening, the governor would be in a position to move back to remote only learning again, but that would be a last resort for sure. So what are those physical distancing guidance? The CDC guidance continues to be that 6 feet distance between kids and desks should occur when feasible. Certainly we know that that may not always be possible given some of the classroom sizes. There is evidence around the world that some countries have been able to effectively reopen with 3 feet distance between students without increasing community spread or having outbreaks in those schools. We know that it's incredibly important to make sure that adults are social distancing. There is increased evidence of higher degree of spread between adults than from children to adults, though again, older adolescents do appear to spread in the same way that adults do. The evidence out of Australia is that in fact a teacher is more likely to get COVID from the teacher's lounge than they are from the classroom itself. We are often more diligent when we are with children or adolescents than we are with our peers. That plays out in hospitals as well, and you see recent data out of hospitals suggesting that in fact the spread occurs in the staff lounge, not with the patients themselves. As we noted earlier, it needs to be developmentally appropriate, and so understanding that physical distancing for a pre-kindergartner or kindergartner or preschool student is going to be much more complicated than a middle or high school student. And so cohorting of classes, so that meaning that that class stays together as opposed to getting split apart, and that teachers actually move instead of having students move through the building. Certainly as we think about elementary schools, that's often continues to be the case, though spacing of desks becomes another issue as children are spending more time at desks. Making sure that those desks are not facing each other, but rather facing forward, and that there's maximizing the space between them to decrease the spread. Again, that continues to be the case at the secondary level, thinking about other spaces that might create congregant behaviors, and so minimizing or eliminating lockers, making sure that there's increased space if activities include increased exhalation. So for gym or sports or singing, thinking about making sure that there's additional room available to ensure adequate physical distancing. There are some specific cases that are worth thinking through, and certainly busing is a prime area which schools have been struggling with to figure out how to effectively do it. Certainly, we want to make sure that schools are following the face coverings that we'll talk about in a moment, but we also want to try and maximize the physical distancing. And so that may be trying to reduce the number of students on a bus, encouraging families to transport if possible to and from school, thinking about other modes of communication, either walking or biking if possible, but also trying to acknowledge that screening of kids before they get on the bus is critical in that. The goals in hallways are really about reducing traffic. So can you decrease the traffic by having not everyone start at the same time? Can you encourage specific traffic flow patterns so that there's, again, less congestion in the hallway? And can you alter the times where kids are shifting classes to try and minimize that exposure? Certainly, kids cannot eat with a mask on or face covering on, and so maximizing the physical distancing requires reimagining where students eat, making sure that you're moving kids outdoors if possible, but also using classrooms and gyms and other spaces to maximize that physical distance. In addition, on the playground side of things, it is near impossible to maintain physical distancing. And so thinking about other strategies that are going to reduce risk, certainly wearing of face coverings, as well as managing group sizes and making sure that the same groups are out on the playground at the same time is an important part. The other piece to make sure of is that if playground equipment is being used, that needs to be part of the cleaning strategy that schools have to make sure that they are minimizing risk of exposure from equipment itself. On the North Carolina side, I think there's some really great recommendations that the plan has, and it is important to note that they are recommending using markings on the floor to identify 6 feet spacing, particularly in high traffic areas. For students and staff. In addition, as I noted, because of the challenges in staff lounge, making sure that those markings occur actually in staff lounges as well, and not relying on staff to keep that distance. There is a very simple way to encourage people to keep 6 feet distance, and that is if both parties hold their arms out and go knuckle to knuckle, that is generally about 6 feet distance between people. Certainly there's a little variability depending on individual's height, and certainly for children, it's not quite 6 feet, but it does start to approximate that behavior and start to help people understand how far apart we really need them to be. Certainly, in addition, North Carolina is recommending limiting of non-essential visitors. That includes parents in buildings and thinking that through. As well as discontinuing activities that would involve larger groups. So thinking about field trips and other components. And on the cafeteria side, making sure that students are not doing self-service, but food is prepackaged to, again, decrease the exposure and the time in line to, again, decrease congestion in those spaces. On the face covering sidelines, there's very good alignment between the North Carolina plan and the AAP recommendations. We both are recommending universal face coverings for use in school for all children over the age of 2. Most children can actually wear a face covering effectively with practice. It does require good adult modeling. It does require we think about sort of some breaks in the day, particularly for our younger children, but also for our staff and older children. Those breaks are better if they're outside rather than inside, but making sure that they are not occurring when people are running around outside, but rather our quiet time that people are not increasing their exhalation there. As I noted earlier, it is critical that staff wear face coverings as well, particularly if they're going to be closer than 6 feet with students. And taking into account, there may need to be some special considerations for those who are teaching language, for English language learners or early learners, and particularly if they're teaching reading as well. The ability to see the mouth is critical in those early language and reading skills. And so making sure that that's a possibility. There are more and more clear masks available that have the ability to help support that type of learning. as we move forward. It is also super important for those who are deaf and hard of hearing to be able to see those actual mouth movement to better understand that. There are also really great recommendations relative to masking and protective equipment for medical procedures that occur for children or adults in school buildings from the CDC. And we do recommend that you continue to follow those, and links exist in the North Carolina plan so that you can find those as well. What about cleaning and disinfecting? Certainly we want to increase hand washing, and in fact the North Carolina plan is recommending that at entry in and out of school buildings that their hand sanitizer are available to, again, try and encourage people to make sure that they are adequately keeping their hands clean as we move forward. We want to make sure that we reduce high touch areas as much as possible. That means that's where you hear about trying to leave doors open so that people are not grabbing that doorknob all day long and transmitting virus through that mechanism. Certainly, we want to make sure that there's at least daily cleaning of those high touch areas. That includes doors, railings, faucets. I would also encourage those high touch areas in outdoor spaces. So that railing in and out of the school building that children swing on and jump on and climb on is certainly not typically part of a cleaning protocol for schools, but is something that should be considered as we move forward during this pandemic. On the ventilation side, clearly what we know is that the air movement and air circulation should be optimized to ensure increased air circulation. And so those HVAC systems are certainly a big piece of that. Certainly outdoor activities as much as possible. Opening windows and doors is viable, but not using portable fans. We do not recommend portable fans because they blow the air more rapidly and in fact may increase the risk of particle spread as opposed to controlling that risk. We also do not recommend any of the air purifiers or portable air purifiers. Most of those are not regulated. They have little proven efficacy, and certainly some of them do produce ozone, and that can have increased environmental effects and increase breathing difficulties, certainly for those with asthma. What about screening and testing? The AAP acknowledges that temperature and symptom screening at schools may not be feasible in person, but regardless, parents should be encouraged to keep their child or adolescent home if they are ill. That plays out for staff as well to make sure that we move that forward and make sure that kids are not and staff are not coming to school if they are sick. In addition, we do not recommend testing for COVID prior to school reentry. The concern is that this creates a false sense of security. We all know about the challenges around the sensitivity of this testing, and so ensuring that we do not use testing in order to reduce the activities of control is critical. What we know from summer camps is that summer camps that did testing prior to entry into camp, who maintained quarantine at the beginning, kept groups cohorted, made sure that they managed those, were able to contain spread. Those that used testing to allow free-for-all and no other restrictions saw some wide-scale outbreaks in those camps. And so it is important to acknowledge that is not going to be the panacea that we would hope. Certainly, staff or students with symptoms should be encouraged to connect with their medical providers to discuss the need for testing. And in fact, the North Carolina plan has some really great graphics to help schools figure out which individuals need to be managed in which way, and are great flowcharts to help with decision-making in schools. So what are the North Carolina screening recommendations? And certainly we want to make sure is that all students and staff with symptoms are staying home. The North Carolina screening recommendation is that everyone should be administered a screening for those who are entering the building for both symptoms as well as temperature screening. And so there are a couple different mechanisms that can be done and some tools that are provided within the guidance that the health department has put out that provide great guidance for schools to think that through. What happens for these kids who do show up sick, and sort of what's the process look like? Certainly, we can expect that many more children will be sent home from school this year when they are sick. Certainly, if you look at the symptom list on the right for COVID-19, those symptoms account for almost every viral illness that a child might have, as well as a wide variety of chronic diseases that kids have. And so differentiating those symptoms is going to be a challenge and mean that schools are put in a hard place where they're not well positioned to be able to differentiate and are going to rely on primary care providers to make sure that that can be done. Many schools are likely to require clearance for pediatricians before return to school is permitted. And certainly for those who have COVID symptoms, we can expect that to be true. And we expect all of this to get more complex as we enter into the flu season. And so the AAP is strongly advocating that everybody, students and staff, be encouraged or required to have the flu vaccine to minimize the exposures for anyone in schools as we move forward. What about what happens when kids do get sick and how can they return to school? And so the CDC return to school guidelines are also being followed by North Carolina, but I will reiterate them here. So if a child has an alternative confirmed diagnosis by a pediatrician or primary care provider and has been afebrile for 24 hours without fever-reducing meds, they are eligible to return to school. Otherwise, they need to be without fever for 24 hours with no fever-reducing meds. They have to have improvement of respiratory symptoms and have to have been at least 10 days from when the symptoms first appeared. Otherwise, if they have had a test and they are 10 days with no symptoms, they can return to school. If they have a known exposure, they need to be out for at least 14 days, even with a negative test. That means that if you're living in a household and someone else in the household becomes sick, it is 14 days from the recovery of that household member. So 10 days from that initial exposure or recovery space, and can be up to 24 days of removal from school in order to ensure safety in that space. What happens when there are positive individuals in school, and what are the recommendations? The original round of recommendations, which are in place in most locations, continue to be that if an individual in one class is COVID positive, that the class needs to be closed for cleaning. If more than one individual in the school is impacted, that the school needs to be closed. If there are multiple schools impacted, that the district needs to be closed. There is some variation that is occurring, and most school districts are not closing down the school district when there are multiple cases across the school district. There is, as we note, increasing evidence of low risk of transmission from children to adults from the Iceland study, as well as the adult-to-adult transition we already talked about. The South Korea study does put in question those children over the age of 10, and so certainly making sure that we're cleaning is important. Certainly we want to make sure that we are isolating sick individuals as well as doing contact tracing and making sure that there's adequate cleaning of those spaces that have been exposed. So for that elementary student who's maybe only in one classroom for substantial parts of the day, it may be just a single classroom. For that middle or high school student who may be moving through the building, it may be much harder to identify the individual spaces and may be a more rapid response requiring actual closing of the school building in order to incur adequate cleaning. The recommendations have been that the school building or the exposed space is closed down for 24 hours before that cleaning gets done. And again, there's variability in different school districts about how they are doing that. I do, on the good side, want to note that school districts that are putting in place these types of control measures have actually been able to see no secondary transmission from either child cases or adult cases. So those schools that are doing good physical distancing as well as face coverings have not had substantial spread in the schools, where that individual case that popped up as the primary case has not caused additional cases throughout the building. That data continues to grow and grow, and we'll continue to monitor it, but it may create different recommendations around isolation for those who have been exposed. and it may change the recommendations around school closure for those positive cases as we move forward. And we're starting to see some of that movement in other areas of the world, though with increasing rates in Europe, that is going to be a harder space for us to expect substantial movement in. What about the mental health needs? Certainly for students and staff, we need to make sure that we're addressing this. There are some great resources listed in the North Carolina plan around how to connect either staff or students or families to behavioral health resources. But what we need to recognize is that a student may look very different than they did when they left school in the spring. We need to know that they may not be as ready to learn on day one. There may be increased levels of anxiety, certainly decreased attention span. Many students may have had traumatic stress during this period of time. And so we certainly want to make sure that we are thinking through how we're supporting these students effectively. It is also incredibly important to recognize that staff can't take care of our kids if they're not taking care of themselves. And so making sure that the mental and behavioral health needs of staff are being supported so that they can teach and support our students and make sure that they can effectively learn. What about children with complex medical issues? Certainly there are massive issues in this space, but really this is about planning. It is about planning and planning and planning and planning. And so making sure that we are connecting with the patient and the family and the medical team as well as the school team and creating an ongoing dialogue. Every child with a medical condition is not at higher risk for COVID-19 or complications of it. And so making sure that we are developing plans that are based on the information that's currently available, as well as being willing to make changes to those plans as needed. Certainly the North Carolina plan highlights the need to making sure that we're working with the individualized education plans and individualized health plans to do reviews. Just like I said around the behavioral health needs of students, our children with medical complexity may well look very different than they did before school went virtual. And so making sure that we are looking at what the needs are today and not assuming that was what was working 6 to 9 months ago is still going to be working. But really our goal is all to be working together to reduce and not eliminate risk, because every decision, whether the decision is to go to school or stay home for these children with medical complexity, but also for the broader population, we know that this is not without risk. And so it is an important space for us to create that dialogue as we move forward. How can we move forward and how can we engage? Certainly it's important that we keep up to date on decisions of the schools that are in the area in which we're working in and that the families that we're working with and that we're up to date relative to those. Certainly you want to keep up to date on what the rate of COVID-19 is in the community, and so using that North Carolina DHHS dashboard is going to be a critical space, but also the Brown University dashboard provides a specific look inside the school buildings and provides some additional data in that space. Certainly we want to be asking patients and students as well as parents about what their experience has been with their schools, how they are experiencing either in-person or virtual learning, what their needs are, and understanding what those additional gaps might be. For those students with disabilities, we want to make sure that we are connecting with the school nurse and the primary care provider, and that we're creating a collaborative team that is working with the family to ensure that those needs are being met, whether that student is in the school or being supported virtually. And as I noted, we can't stress enough the need to make sure that we are supporting the behavioral and mental health supports that patients, students, and their families need. Certainly, we know that families have been strained in this time, and that may well not yet appear in the student, but making sure that we're supporting those families as they navigate this pandemic as well. So here are some resources for you. Again, the AAP resources, as well as some parent-facing resources with Healthy Children and the tracker that I talked about under Burbio. You can find the North Carolina website quite easily, as well as the Brown website is easily available as you move forward. And with that, we will open in the floor to have a dialogue and answer some questions.
Thank you so much, Dr. Beers. Do others have, this is a time to have questions. So if you'd like to type into the chat box, and I'd encourage you to do so. Actually, I wonder, Dr. Beers, if you wanted to share, I don't know if you have a link or if it's a difficult and long link for the Brown University data. I will say it's curious that they had that we're 88% in person, because some of the stats that we've been following is we probably had about 1 million who were virtual, and our state decided to go with Plan B. So when actually schools were returning, our governor decided it was going to be Plan B. So it could be a hybrid. It could be, you would have to offer some virtual, but people could be, that was the floor. But schools, districts, and schools could certainly offer Plan C. And my understanding is we had about 1 million kids in most of our big school districts, and most of the districts we had them virtual only. And then we had some hybrid and some in person, but there probably were about 700,000 kids that were in person. We are just recently, October 5th marked that now the governor has allowed 5. He made the announcement on September 7th. So, excuse me, September 17th. And I know school districts are now, have been looking about that return to in-person learning. So it'll be interesting to see a lot, like I said, most of the schools have had a lot of them virtual, and some of them obviously offering the modified, where some would be able to come in person. So that's interesting. So I'm really interested to look at the Brown University data as well.
In the chat for anyone who'd like to sort of look at it a little bit more carefully. I will note, right, I don't know a ton about sort of how many school districts are in North Carolina. They're reporting that they've had responses from 100 different schools. Some of those may be private schools, though, as well, that have put data into that system. They may not all be public schools, but that's an interesting piece. It's interesting as well, because when I was looking at that data and looking at compared to the Burbio map, it didn't look like those two systems were jiving up. And Burbio has done a little bit more, I think, analysis of actual schools and not relied as much on self-reporting of data. I think we may have lost Jerry. So if you have questions, please put them into the chat, and I'm happy to address those as well. It looks like Jerry may have frozen and had to drop off and jump back on. So. I'd love to hear if anyone wants to put into the chat any comments around sort of what the local experience has been in North Carolina, and sort of what the families are feeling about the choices that they're being afforded. I think there certainly has been a wide range that I've heard of around the country about the issues that families are experiencing and how they feel about return to school as an option. And so I'd encourage you to put into the chat what experiences you've had, and certainly we can have a dialogue around that as well. Oh, that's a good question, actually. I didn't talk about this. So there's a question around recommendations for PE classes, particularly around elementary schools, or as well as sort of after-school physical activity programs. So the AAP does have a statement specifically around return to sports and return to activities there. And like some of the recommendations that I think North Carolina has put forward around that is around how to think about the different sports being potentially needing a different response. So certainly those sports that allow more physical distancing, it's a little easier to do than those that don't. And so that's a good place to start to look. And then looking certainly at those sports where it's just not possible to physical distance, right? And so certainly wrestling is a sport that comes up frequently where the whole point of the sport is to be up on somebody. And so it's not really possible to think about that. When we think about PE classes or physical education classes, I think it is about thinking strategically about how we can create physical distance between those students, making sure that we are, again, potentially using markings. I've seen some great programs where teachers have put down hula hoops on the floor and encourage students to stay in their hula hoops. Again, using face coverings or masks during PE is another important strategy for kids to be able to enjoy that time in the day. And then as much as possible, having that occur outdoors as opposed to indoors where there's more space available is going to be a great strategy to sort of help encourage students to remain physically active, as well as creating the space that they need. I think certainly there is more and more evidence that children are not as active as they should be during this pandemic. Many of us adults as well struggled with maintaining our physical activity during the pandemic. And so using PE classes as a way to help that happen. I actually have two children myself, a high school student and a middle school student. And for the middle school student, for his PE programs, they are actually entirely virtual. And so they do some asynchronous PE classes where the students get some exercises. There are some demo that they can watch if they're unsure how to do those exercises, but they're able to do them by themselves. But then they get together and actually have a virtual PE class that is synchronous or live. And they've been able to do some really great work where kids help lead the exercises. And it's been a great opportunity for the kids to exercise together and socialize and laugh and be silly and have fun, but also be able to move inside their house. And so even those students who can't safely go outside have been able to engage with that. And so certainly thinking about that is an important strategy. The other thing that I'd comment on around sort of extracurriculars that comes up is the issue of band or orchestra, as well as choral groups. And the unfortunate reality is that we know, particularly for the wind instruments for band or orchestra, and also for choral groups, they are high particle spread experiences. And so the really only safe way for them to occur is in really truly maximizing the distance between students. And so that means making sure that there is at least 6 feet, preferably 12 feet, and that these activities occur outdoors as much as possible. Again, making sure that students are not facing each other, but they are facing away from each other or facing lined up with adequate space in between them. But that is another area where, unfortunately, as a former, singer myself, it is not necessarily something that is easy for people to be able to do effectively. So we do need to sort of keep that in mind as we remember that. And it looks like Jerry may be rejoining us. Here she is.
Thought you guys all left me, and apparently I left you. Sorry.
That's all good. So we were talking about PE programs. In fact, the platform that our school district is using is Microsoft Teams. And so that is what they've been using for those PE classes. And the teacher has been loading those up onto Microsoft Teams. Certainly it's possible on other platforms as well. There are also some virtual exercise programs. Both of my children play travel soccer, and they have been using some of the fitness apps that have some pre-recorded physical activity. So both Nike and Peloton, as well as several others, have some virtual opportunities around PE. There is also some younger work. I've seen some virtual modules for pre-kindergarten through sort of second or third grade, where they're doing yoga and stretching and learning about their balance and bodies. And so there are some really great tools out there that are worth exploring if you are in that virtual space and trying to think about how you can create that opportunity for movement, which can be so important to occur.
Great. That sounds like those are important. And I know I've heard a variety of different platforms that people have been looking into for virtual PE. So those sound like great additional resources. I know the North Carolina High School for the North Carolina High School Athletic Association, I know that they have come up with lots of recommendations for sports participation, for practicing, and for social distancing. And they keep updating information there for older children as well, for again, that in-person. And again, the non-contact sports are those that are clearly preferred. And then for some of the other sports is doing drills and other things where you're not actually playing a full game. I know that has been their recommendations. And there's some great guidelines as well from the Department of Health and Human Services, which are consistent with our North Carolina High School Athletic Association as well.
Yeah, and those, as I said, I think sort of grade 8, sort of like what sports sit at what level of risk. And I think it's a great sort of way to help families and children and staff understand, if you really step back, why things sit at different levels of risk. And so, I think certainly, those things where you've automatically got, 50 to 100 feet in between you are a lot easier to do than those that have you pressed up on each other.
I have a question. I know that for, I don't know how standardized, so I can really speak to the North Carolina High School Athletic Association because I'm familiar with theirs, is in order to play in sports, and I don't know if other schools and districts are doing this. So for those of you who are on, please, I'm learning as well, because it does vary some by district. There is a form if you have been sent home with symptoms to return back to sports. And obviously that you want to have, I don't know if schools have developed their forms, but I know for high school athletics they have. And then if you have been found to be positive for COVID as well, and they're actually physician clearance to come back to school. I know that it's not required in childcare to have a note, but I do believe in schools for a kid to have been home and have found to be with COVID. I'm curious how that is being operationalized, Dr. Beers, and then as well as in schools, because I know that can be very challenging, as well as the screening for symptoms and asking them to be excluded from school and then to return with those. I don't know if people have developed what they've developed and what you've seen, Dr. Beers.
Yeah, so I think this is a huge area, right, for where the AAP updated their guidance around return to sports. And initially had much vaguer guidance around sort of what kind of clearance needed to occur to return to sports. As the data became more clear that there are potential long-term cardiac outcomes and impact of COVID-19, even in children, that the decision was made that, in fact, the AAP does recommend pediatrician clearance prior to return for sports for those who have been found to be COVID positive. And so, I think that certainly comports with, I think, what North Carolina is doing around return to sports. I think the challenge exists, as I noted, right? There's a whole litany of symptoms that look like COVID that may not be really very predictive of COVID when we think about entering into our typical flu and cold season. And we also know, and I didn't note earlier, the challenge that exists because, in fact, we do know that COVID can coexist with other illnesses like flu and strep throat. And so just because you've got that rapid strep test doesn't mean that you're cleared from COVID. And so there is this challenge that exists for providers around, does that mean I have to test everybody for COVID? And what are the implications on the capacity of the testing environment to sustain that? And it's different in different environments, right? DC has been very fortunate that we've been able to get turnaround times in the sort of 48-hour range from pretty early on in the pandemic. But there are lots of jurisdictions where the turnaround time was, over 2 weeks. And at what point is that test actually valuable, or do you make a presumptive diagnosis? And if you're going to make a presumptive diagnosis of COVID, what are the implications then on sort of other components? And I think that is where, right, sort of understanding what's possible in your community and knowing what the turnaround time of testing is going to be an important piece of this. Certainly we know there's some symptoms that are much more specific for COVID. Essentially the statement now is if you lose your sense of taste or smell, you have COVID, even if you have a negative test, right? Because of the sensitivity of the test itself, that is what most providers and public health experts are saying at this point. Now, whether you get into then the database as a COVID positive person or not is a whole nother issue, but I think that's a challenge that exists. And I think, as I noted in my talk, the real challenge is going to be when we hit a viral season and pediatricians and other practitioners seeing children are unable to deal with the volume of kids who they typically wouldn't see. Because, right, if my 12-year-old had a cough, would I take them in to see the pediatrician? No, I'd wait a couple days, see if they got better, see how things happen. But if I can't send them to school, and am I going to take them to the pediatrician now? Maybe, if that's going to get them back into school faster. And is the medical community ready for that type of onslaught of COVID testing requests and just physically seeing patients? And so a lot of practices are talking about trying to figure out how to do some telehealth screening to determine which kids really are sick enough to bring into the practice and test, and which kids you need to sort of talk with families about monitoring at home and coming in if they get sicker. Because we're not going to be able to see everybody in our practices.
Right. And in North Carolina, a couple of comments is there's been a lot of effort and investment in people as well as in funds and contracts to make testing available in historically marginalized communities. And we've set up pop-up testing, and that's become much more available than it was, and not just at the doctor's office. And actually testing in many places is free and has been subsidized for those who don't have insurance. So it doesn't require that you have to go to a provider office. Obviously that information needs to be shared, but this is to basically facilitate getting the testing and not having the onslaught as well. And then there was a time, and it wasn't just here in North Carolina, that the turnaround time for many tests was like, 6 to, several days to up to a week. That turnaround time, and we keep track of that, has gotten a lot better. I do know there are some rural areas, and I would be curious with anyone on the call, because I know that in Robeson County, there were still some challenges, but I think most people, the turnaround time has significantly improved to 1 to 2 days in most places. And again, like I said, with the access to be able to have that testing. I've also heard, although not officially, is that there is some of the antigen without without symptoms in some of the areas, and look at populations where there's higher percentage positive in the community to kind of be monitoring for that in different areas. I know in nursing homes where they're doing regular testing of staff. Obviously that's not the same as schools, but as staff and nursing home residents. But I know they're trying to make the testing available to schools in partnership with health departments. The other thing that you have here is you have mainly health departments that are on here, and it's the communication with the schools and making sure that they're aware of kids that are being sent home and then are found to be positive, and that communication between the schools, that does vary across the state, but there's a lot more efforts to, I mean, some counties do a great job, and obviously health departments have always been partnering with schools, but I think some of that has been challenging about where all that information, because they could be reported to the state and the health department may not know about it, or the school, and vice versa. So making sure everybody knows about all of the cases for contact tracing, as well as for other resources.
Yeah, and that communication between public health departments and schools is just so critical, right? It's that information sharing in that bi-directional way, right? And I think, you know, there's huge variability, as you note, right? Some of those relationships are super well established and are very smooth, and everybody knows each other and it works really well. And I know who to call and you know who to call, and there's really good communication, right? And then there are sort of challenges that exist in other jurisdictions that create sort of additional barriers. Right here in DC, in fact, in our 10 square miles, we have over 60 different school districts because each individual charter school is a separate school district, and we have a very active charter school movement here in DC. And so that means sort of for the public health officials, it's not just getting in contact with the DC public schools, it's figuring out which school that kid is at, and the individual school may have an individual right? So there's some additional layers of complexity, and our education system and school system have been trying to sort of, during this summer, sort of create the flow of information so that it's possible to think about sort of what does return to school look like. Most our schools are still virtual. Some have just to some in-person learning for high priority populations, of those who are homeless, of those with special education needs, recognizing the struggles that exist in the virtual space for those in particular. And we've started providing for families who need it some safe spaces for students to do virtual learning inside of school, where they're not getting teaching, but there's at least an adult supervising some virtual learning. There's a quiet space, there's a desk, there's space in between them and other students. They can get their lunch, all of those components that could be critical to ensuring that they're accessing education. But those, you know, are variable from school district to school district, and certainly for you as public health officials, the challenge is navigating that space and figuring out who can be a good partner for you to share that information in a bi-directional way.
Right. And obviously it's important for schools and health departments, and there is an executive order for all positive antigen as well as obviously testing to be reported to basically health departments, but the health department where the child lives. And so some of it is where you go to school and the district that, I mean, so some people are going different places. So making sure the information gets to the correct places. And it may come to the state before it comes to the local health department to know, because people may be actually in different parts and cross county lines.
Right.
Because we know COVID doesn't stay, you know, doesn't follow lines and follow borders necessarily.
Not very well
between,
so far.
No. Questions from people who are on this, because this is an opportunity to ask. I would encourage you to do so. I'll make one comment. I know that for our schools, and that so basically and actually not just for school, the requirement is for wearing masks down to age 5. Now, obviously, that's the requirement. Of course, we encourage and are strongly encouraging down to age 2 because they can be, you know, wearing those. I'm wondering, I've heard some about, you know, some wanting to have medical exemptions for wearing masks, and then also how to have children using masks and modeling the use of masks. I've heard, you know, I've mixed things. I've actually recently heard about a childcare company that's not just limited to North Carolina banning masks use in their childcare facilities, which is interesting. Yes, very unfortunate. But I wonder, for people who are on the session, or Dr. Beers, if you want to comment about how use of masks. I know there's a lot of resources out there, and the AAP has, been promoting some things in different areas across the country.
Yeah, I mean, I think there's a number of resources, right, as you note, right, certainly, and sort of one of the things that people really worry about is children's ability to effectively wear a mask and safely wear a mask, right? And so, the first thing is, how do you put it on and how do you take it off, right? And there are some, great videos out there around sort of supporting that, right, for various different ages that exist. And so that's sort of, piece one. I think piece two is, as I noted during the discussion, it is about practice, right? And so it is about making sure that we are giving kids the opportunity to practice, right? If your kid is in a virtual environment right now and you think that they're going to all of a sudden go to school and spend 8 hours a day in a mask, you're out of your mind, right? It's not easy for me, right? I just spent this morning in clinic, right? And sitting in clinic for 4 hours in a mask with no break, because I can't take a break when I'm in the right documentation area of the clinic. I would sort of on the go all the time, right? And that's a long period of time to sit there in a mask. So, right, I was lucky, right? I had a break. I was able to walk to my car. I could take my mask off when I got in my car, right? And sort of, go to this event. I think we have to create those same types of breaks for kids as well if we think they're going to be successful. And certainly younger kids are going to need more frequent breaks. But I would say with an adolescent upstairs in my house, she probably needs breaks as well, right? And so just thinking that like all of a sudden, because they're 15, that they can sit all day in school and we're not going to give them designated breaks, they're going to do it anyway. So we should make sure that we control the situation, right? On the medical exemption piece, right, this is certainly a huge hot button issue. And I think there are very few meaningful medical exemptions that exist. One, that child or adult who has a physical disability that makes it not possible for them to effectively wear a mask. Do you have some deformity from your ear or your face or something that makes it literally physically not possible for you to wear a mask? Even those individuals who have limb abnormalities can effectively wear masks. They need support getting it on and off, but there's not a reason they can't wear a mask. The other big issue that people come up with is, oh, I'm an asthmatic, I have whatever lung disease. But unless you have a lung disease that literally is impairing your ability to breathe, right here, right now, you can wear that mask. We know that kids with cystic fibrosis, kids with severe asthma are able to wear masks for prolonged periods of time without any impact on their oxygen status. And so while it may not be comfortable, it doesn't negate the fact that it's not a medical exemption. There are individuals who have sensory deficits, right, and sensory difficulties, and certainly those individuals on the autism spectrum disorders, where there is a sensory issue that makes it really challenging for them to wear a mask. And so there are some tricks and techniques around that, right? Certainly, we use all kinds of behavioral incentives for kids to try and encourage them to do all kinds of things that they don't normally want to do. And so certainly not being afraid of using those behavioral incentives to have them earn special time on the computer or special time with a parent or a teacher or whatever is going to motivate them, or sticker charts to be able to do that. And you may start with short periods of time. And certainly for those who have true sensory aversion, it may be important to start with 5 seconds and build your way up. And have them get rewarded for each of those steps in time. And then finally, I think there are those who have some level of anxiety, and the mask actually creates additional challenges around anxiety. And so those are really the sort of 4 categories where you really truly could create some type of medical exemption. And yet we know there's all kinds of people who claim that they're unable to wear a mask because somehow it's impacting them, right? And yet we know, right, there are people who, have, run very long distances, done extreme exercise, and monitor their oxygen status and not shown any impact on their oxygen status. And so for those who've come into my practice or come into our practice who've laid claim to needing to get those, we actually are putting them on a pulse ox and having them, move around and showing them that in fact there's no impact. And so from a medical perspective, I can't justify it, right? And so, that works with some families. It makes some families super mad at us, but unfortunately that's a challenge that we're all sort of struggling through. And yet the data is more and more that the masks actually have incredible impact in controlling disease, even in spread from someone who is asymptomatic, and most critically for that individual who's asymptomatic and in the building, that I'm at much less risk if we actually both are wearing masks.
I have another question. I know busing is huge. And do you know if there have been some best practices that you've seen other than, the 6 feet but how a school district manages to still, obviously like I said, over half, probably 60s have been virtual. And so most of it, but as they consider, I guess, for the K to 5, and if is, that challenge of busing and then being able to get everybody, or at least, to be able to socially distance on the bus and then to bring the students and to be able to actually get that accomplished in a reasonable amount of time to actually have a school day.
Yeah. I think there's a couple different strategies that I have heard of or seen sort of in my conversations, right? I think certainly the most critical, right, is the face coverings, right? Because there may be some times a year where we can keep the windows open, but the reality is face covering is going to be incredibly important in that space. Another place that I've seen schools be more restrictive in or more prescriptive in is in assigned seating, right? And so thinking about sort of, this is your seat always, right? Not, space, but Johnny, you're going to sit here. Katie, you're going to sit here. That's always your seat. That allows us to, again, create almost like a cohort on the bus, right? Where there's smaller degree of exposure as I move further away from the other individuals. So other busing recommendations have been around sort of having vacant seats, right? So putting X's on seats that, can't be used to try and stagger some of that if there's enough space on that bus to make that possible. To increase the ability of having space, there's also school districts, and this varies depending on how far the buses have to go and the feasibility of this. And so certainly for more rural districts, this becomes much more challenging than some more urban districts. But certainly thinking about start times where there could be multiple bus routes that occur. And some school districts do this already to think about sort of elementary school or middle school or high school and different sort of schedules to try and sort of loop them through. But could you have those cohorts be different, right? And so in an elementary school, do you have a pre-K through second grade cohort that's on the bus and starts at one time, and then there's a later start time for your 3rd through 5th graders? Right? And do you start to sort of, again, try and group kids into smaller cohorts that allows you potentially to have some additional time on the bus? And then, as I noted, there are school districts that are really encouraging parents to do transport as much as possible, right? And again, it's just about decreasing the burden on the bus so that there's fewer kids on those buses at any given time.
Right. And I think for North Carolina, which I believe I heard, I don't know if it's 70 counties out of the 100, but a lot. If it's not 70, it's close to, are rural. So we have the challenge of being able to get kids and parents being able to obviously get to work. And so having parents it's not always an option, obviously, for parent transport, but for those who can, it definitely unloads some of that burden and it helps with that process. So that makes sense. Definitely. Great. Do you know, I'm going to keep asking you a question, hopefully. do you know if there's been, I know that there was like the census pulse data, and there's been some data collected about COVID. And I know it's early, but do you know if there's any data about return to school and impact, and if that's been done for families or children? I think everybody's talking about surveying. I don't know if we've seen the data yet. I even heard the National Survey of Children's Health is looking at making sure that they'll start adding, they're going to be adding some questions, not for 2020, but for 2021, once they kind of test the feasibility of the questions about asking about impact of COVID on a number of things, not just on education. But I just wondered if you knew of any data or people or agencies that are about to collect that data for schools, for maybe even school personnel and staff, as well as the children and the families.
And you're talking about the impact of COVID when folks return, not the case rate data, right?
Correct, when they return.
Yeah.
Mm-hmm.
I don't know. Well, I've not seen anything yet or heard anybody who is doing that level of analysis. I know there are several people sort of looking at couple different areas, right? The CDC has started to try and figure out how to effectively track the number of cases that are related to schools.
Right, and we're doing that at a state, and we actually
Yeah.
haven't seen an increase, but right, so yes, that's great that they're.
And then Johns Hopkins School of Education has been doing some analysis of state plans and looking at how those have shifted and how effective those are. And they have their also case data on their public health side that they track. And then there was this Brown tool, but I don't know that any of those have really started to ask the questions about impact on families and on resources and ability to return to work for parents and family members, and ability to, improve the nutrition status in the family. And so I think there's some interesting potential to start to think about that. And I think, as you noted, right, the census pulse data is been trying to sort of ask about the impact of COVID, but I don't think they're overlaying that question of if you have kids in your household, are your kids to school, and does that start to change what because the data around adequate food access is horrifying in that pulse data, and does that start to shift as schools start to return to in-person classes? Okay,
great. I mean, I'm glad to hear that they're looking at, some of the other data. That makes sense to be looking at the plans and as those change, because that's going to be definitely important, as well as cases.
Right.
Okay. Well, everybody seems quiet. I think, I guess at this point, we'll give people another minute or so, but I would like to take this time to thank you, Dr. Beers, for coming and presenting and sharing. And I know we are not done with this pandemic or learning how to do things better and smarter, and also figuring out ways to support schools. Obviously, the gaps for in-school funding, as you highlighted, and resources are highlighted even more by this pandemic. And so potentially, bringing more resources into this space for not just the physical space, but also obviously for mental health and behavioral health, and for, safety for schools and for the children and students, as well as their staff, is so important.
Yeah, I mean, it's been my pleasure to be here, and I really appreciate all the work that you guys are doing here in North Carolina, right? I mean, I think, you shared the North Carolina information, and it's really well thought out, deliberate planning that is going to make a safe return to school possible. And North Carolina has clearly been doing some of that really important work, and making sure that you are answering the questions for parents and families, as well as staff, about how to effectively reopen schools. And I think school districts are really fortunate to have a partner who is doing that. And so certainly any way we can help out from the AAP side to support that work. I put up the Council of School Health email. You're certainly free to email me too if there's additional questions that come up. and certainly happy to try and connect you in North Carolina to any resources that I'm aware of, and look forward to continuing to share as we all learn together how to address the pandemic, as well as how to safely support all the children and adolescents and the needs that they have across the community as during this pandemic.
Well, thank you. And as we know, the challenges for schools and for health departments is it varies, and that the resources for a school and the ability to, it's a